Top Med Talk.
Hello and welcome to Top Med Talk. I'm Kate Leslie and I'm here with my co-host Mike Grocott at the combined meeting of the International Anesthesia Research Society and the Society of Critical Care Anesthesiologists in Honolulu in Hawaii. We've interviewed some great guests so far, Mike.
It's been brilliant. It's been superb. I've actually only done Top Men Talk in Hawaii. I'm not going to go into my travel fiasco again, but
It involved Heathrow fire.
Yeah, having had a travel fiasco, I've turned up and so far only done interviews, but I think I'm getting essence of the conference from our really excellent contributors.
Yes, we've talked to Dan Cole about the APSF most viewed paper for 2024 about hypotension. And we've talked to Dan McIsaac about frailty and his wonderful PREPARE trial.
And we couldn't find another Dan, so as an alternative, we have a special guest who is?
Yes, Sandy Jackson. Sandy, can you tell us a bit about yourself?
Yeah, sure. Great to be here. I'm an anesthesiologist and critical care doctor in Southampton, but my research interests lie in clinical data science. So I'm interested in using data that we collect already on patients and using that for risk evaluation to try and improve the way we evaluate risk.
You've come here to present some work or to listen to other people's great results?
Oh, I mean, it's great listening to other people's results, but yeah, I came along to present the results of a pilot study which we've undertaken called Cipher HPI. So I'll spell out some of those letters for you. So for us, Cipher is a kind of wider-ranging project which is to deal with continuous, iterative, perioperative, holistic evaluation of risk. You can string all that together, you get Cipher, which also sounds quite kind of modern and algorithmy and clever. But essentially it's this idea that why should risk evaluation stop at the pre-op clinic? We should use all of that rich data we gather throughout the patient journey to try and enhance our risk evaluation for outcomes that are meaningful to clinicians, hospital systems, but also to patients. So it's clear it's a huge project and we had to pick somewhere to start. So that's where the HPI bit comes in. This particular study was funded by colleagues at Becton Dickinson, so BD, Advanced Patient Monitoring, which some of you may have known in a previous life as Edwards Life Sciences Critical Care. And they have a proprietary algorithm called the Hypotension Prediction Index, or HPI. And we basically used all the preoperative data that we would normally integrate into risk evaluation, along with all of the advanced hemodynamic monitoring data and the HPI value from BDAPN's hemisphere monitor, and integrated that into some models to try and predict, in our case, whether people would basically need vasopressors or fluid after surgery.
Where did you get the data from?
So it was a consented study where we had 143 people in the final analysis. There's a few that data didn't quite work out and things, but they were all patients in our institution who were going to have a CPET as part of their workup, which accounts for a lot of our patients, but who were basically going to have intermediate to high-risk surgery. So these were people mostly having oncological resections, things like cystectomy, so pretty big surgeries, who were going to go to our level 2 unit, a surgical high-dependency unit. And for those of you, different countries have different definitions, right? So for us, that's single organ support. So they would maybe have some vasopressor, but they wouldn't be ventilated. So it was that cohort of patients that we knew were going to have an arterial line in. We said, carry on with everything you're doing normally. We just want to put some advanced monitoring and take all of the data from our anesthetic monitors and all of the data from an Edwards monitor. But the clinicians were still blinded to that. So they didn't see the HPI, they weren't acting on it. It was just helping us learn about what that looks like.
And what outcomes were you looking for in the pilot study? Did you have efficacy and feasibility outcomes?
Yeah, for us, the feasibility was more, can we actually just collect this data? Can we get the data reliably out of our anesthetic machine? Can we get the data reliably out of the hemisphere monitor? And can we find and identify the right cohort of patients? And I think we achieved that. Then what we were more doing was some exploratory work. What outcomes do we want to try and predict long term? And we felt that one of the most useful ones for the hospital systems that we're working in would be to make more efficient use of those precious high dependency unit beds. And the way we felt we could achieve that is by identifying the people that need to go there. And if you look at the ARC trial, which is an advanced recovery room care trial from one of our collaborators, Guy Ludbrook in Australia, they basically found the main reason that people were needing to go to their ARC was because of hypotension or hemodynamic instability. So what we wanted to predict was people who would need vasopressors or more than a litre of fluid given as a push bolus in a hurry, because we think that's something that's best done in a HDU setting and isn't as well managed on the floor or the ward.
So for our listeners who are not familiar with the BD-HPI product, is there additional kit that's required?
So it would be, you put in an arterial line just like you normally do. you would get their specific transducer, so their Acumen IQ transducer, that will then plug in, and you can plug it in to your normal anesthetic monitor, but you then also plug it into their hemisphere monitor, which gives you the full suite of cardiac output monitoring.
Awesome. And what were the results?
So what we did was we did some stepwise logistic regression to see what things help us predict that outcome I spoke about earlier. And we found that trying various different permutations, whichever way you worked it out, the HPI data, so the time-weighted average, so basically how high their HPI was above a threshold, which we set at 50, and for how long, was more powerful than the same thing done with a MAP of 65. So if you did a time-weighted average of MAP and a time-weighted average of HPI, the HPI value was more predictive of who would go on to need vasopressors or fluid. And what we actually found was that the recovery room data in your kind of PACU setting, those 2 hours after they've woken up or are waking up from their anesthetic, they were even more predictive than the intraoperative data. So actually putting a device like this on for 2 hours in the recovery room gives a huge amount of information to help us predict who might then go on to need support.
So why is that? Is it because during the operation the anesthesiologist or anesthesia provider is right on top of the blood pressure treating it all the time, and in the PACU there are, delays and longer periods of hypotension, or is there another reason for that, do you think?
It's hard to be certain from the data, but if you ask me to hypothesize, I think it's actually that there's more noise in theatre, right? So there's a surgeon cutting the patient and causing some stimulation there. Yeah, you've got the anaesthetist who might be giving drugs to push the blood pressure up or down, or giving fluids or other products, whereas I think once they get to recovery, particularly in this cohort who are being extubated, who are waking up, you're starting to get them far closer to what they're likely to be either in HDU or the floor. So it's probably more representative of what the next 12 hours are going to be like.
And Sandy, if I'm right, the HPI algorithm was not validated for that. So as I understand it, it's for prediction for people under anaesthesia during surgery as opposed to after surgery. It's just we've used that variable for a different reason.
Yeah, absolutely. And I think you'll see there's been gradual evolution of the HPI algorithm. So when it first got its FDA approval, it was above 85 is predictive that you're going to drop your blood pressure in the near future. They've now changed, the FDA have approved it being used above 50 as a warning of potential oncoming instability or hemodynamic instability. And we essentially extrapolated that when, well, hold on. If it's finding instability from the arterial line trace, which is almost certainly reflective of probably microcirculatory and early compensatory mechanisms that our bodies are doing before hypotension occurs, if we're picking those up in an anesthetized patient, there's no reason why they wouldn't exist in an awake patient. You're right, it's probably not within the FDA license, but I think it's interesting exploratory work, and certainly this is a pilot study and we'd love to take it forward to a larger project.
And interesting that the information is generalized, because we're using it in a different way. We're saying what happens hours later as opposed to, within the next 15, 20 minutes and in patients who are awake. But whatever it's picking up appears to have relevance under both contexts, which is intriguing.
Yeah, absolutely.
So what's next after this, the Cipher HPI pilot study?
So as I say, Cipher is an ongoing project, and I think there's kind of, in my head, two missions. There's more patients, but there's also more data. And by data, I mean kind of the breadth of data, but also some of the approaches by which we look at that. So obviously we need more than 140 patients. Appreciate that. And we're going to work hard to get support to recruit more patients into the study. But I also want to start collecting more variables from across the pathway. So as we develop more tendrils into the computer system, into our electronic patient record, we can start pulling more variables about our patients, both inputs, so things from the clinic, from their preoperative journey, but also outcome data from that post-operative period. And then I also want to start looking at those variables differently. So at the moment, I've used a summary value, that time-weighted average number of the HPI during surgery and the PACU. But I think the real value add will come when we start applying more sophisticated machine learning techniques, so time series analyses, to try and understand not just what the whole picture was like, but the patterns over time.
So I was waiting for you to go all AI geek. It had to come in at some point. Some of the analyses you did of the pilot data, as I recall, started to use machine learning type techniques. And one of the things I found really interesting, they're obviously very smart techniques, but the ability to say, if you get more information, we will be able to achieve more resolution. Can you talk a little bit about that?
Yeah, sure. So, I mean, I'm a data scientist. I couldn't resist building just a little machine learning model. Yeah, and when you build these machine learning models, what you can produce these things called training curves, which essentially show how the performance of the model changes as you add more data into it. And you see two curves. If you kind of Google this, you can find training curves, and you'll see the two lines, one coming from above, one coming from below, should converge together once you have kind of reached your optimal point. When I did this with ours, we hadn't converged yet, and you could just see, tantalizingly, if you projected those curves out with more patients, we would definitely improve the performance of the machine learning models substantially.
Fascinating. Thank you.
I often wondered while you were talking about, time series, this and, average of time weighted value, blah, blah. And I can't imagine being in an operating room and singing out to the surgeon, I'm really concerned because the time weighted average of the mean arterial pressure is 5,050. And they'll go, what do you mean? So what are the processes, do you think, of making these sort of sophisticated machine learning numbers or even just normal computed numbers meaningful to clinicians?
Yeah, I think that's actually one of the biggest struggles with all of these artificial intelligence technologies is the implementation piece. It's exactly that. How do you make it usable? And I think for us, I don't expect us to produce a number. I think we will end up with, in effect, traffic lights or guidance, if you like. And ours probably isn't going to be used in an immediate intraoperative context. I still think the trained anesthesiologist is going to be the person making those decisions in the moment. What we want to be is a kind of decision support on steroids for when you're called to PACU with someone the nurses aren't quite happy about, that's been there for 2 hours. They go, we're just not sure. We're not really happy to send her to the ward. And you're you don't know this patient, someone else anaesthetized them, they've now gone home, and you're looking at them going, do I send this person to the floor or do I take up one of my valuable high dependency unit beds? And actually at that point, you would put the data into an algorithm. It would give you some information, say their hemodynamic profile looks like they may well drop their blood pressure in the next 12 hours. Now, it may say it's not going to, but you look at them and you just know you've got a sixth sense as a clinician. There are other comorbidities here. There are other things I'm worried about. The ward's understaffed and actually we've got loads of critical care beds tonight. Fine. Overrule the algorithm. The algorithm doesn't know it all, but it's there to support you. And I think that's about the right thing. It's putting it into context and giving the information for clinicians to make the right decision for the patient in front of them.
And I guess the corollary of that is that similar types of data, if you do choose to send the patients to a less intense environment where maybe the nursing cover is relatively thin, is that the same types of devices using the same predictive technology can start to ring an alarm bell if things look to be heading the wrong way.
Yeah, and I think that's the really interesting thing is you start looking at some of the more advanced non-invasive blood pressure monitoring technologies that can do continuous hemodynamic monitoring, but without the need for an arterial line that a ward wouldn't be comfortable to manage. Yeah, if you can put those on patients going to the ward, you potentially have the scope for early warning and essentially getting over this failure to rescue concept.
Sometimes frightens me that our patients on the ward get less attention than they would if they'd gone home and they were with their nearest and dearest, because our ward staff are so stretched overnight.
Yeah.
So for our listeners out there who are interested in data science and AI, how does a medical student or a junior doctor get up to your level of expertise in those areas and beyond?
Yeah, great question. I mean, I think it does still build off fundamental foundations. So I do come from an epidemiological background. I've studied epidemiology at university, and there's no question having a basic grounding in good medical sort of statistics is important. Then I was initially fairly self-taught. You go online, you find courses. There are some great courses out there on introductions to machine learning. They're freely available, these kind of massive online courses, the MOOCs, if you like. Then I went down a more formal route. So I actually did a master's in data science at the University of Edinburgh, and that was extremely helpful. But I've then actually gone and jumped in and done a boot camp in a kind of a trendy East London warehouse where I was surrounded by guys who were doing learning data science to go and work in finance or in industry. Nobody else medical. It gave me a totally different perspective on how out in industry where AI deployment is through the roof, they do things. And that's let me bring a lot of, I think, quite cool ideas back to medicine that I'm hoping to start integrating in some of what we're doing.
Well, I think we need to encourage our emerging leaders to do this kind of work. It's a bit late for us, Mike, maybe?
I think we're a lost cause, but I do think that, trying to attract really smart mathematicians into medicine, doing dual credentialing with this kind of data science expertise alongside medical expertise is going to be really, really important if we're going to make the most of all the data that we definitely will have. We already have.
Well, a lot of medical students, including me, were good at maths at university, but once we got into medicine, we really never used all of that knowledge again.
Yeah, I think good at maths a couple of decades ago probably doesn't stack up with modern data science. I'm sure you were brilliant, Kate, but
No, not that brilliant. No. Oh, well, Sandy, so what's next for you?
I've got a couple of irons in the fire, so still working on securing funding for the next part of the Cipher 2 project, and I'm also working with our national perioperative quality improvement data to try and map trajectories of more patient-centered outcomes. So rather than creatinines and complication rates, I want to look at disability and quality of life after major elective surgery.
Awesome. Well, we wish you all the best of luck with that program, and thanks so much for being on the podcast.
Thank you ever so much for having me. It's been great.
thanks for talking to us.
We'd like to thank our sponsors, BD and also GE Healthcare. We're very grateful for their sponsorship because without it, we wouldn't be able to bring our content free and open access to the world.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.